Hello, everyone, and welcome to the NNN workshop on applying gender equality and inclusion in NTD interventions to achieve equitable health services. We're going to start with some of the housekeeping notes for the session. So during the session, you will enter the workshop with your camera off and audio muted. Please keep your audio muted to help keep background noise to a minimum. If you are invited to speak, please unmute yourself by pressing the microphone on the bottom left-hand corner, and feel free to switch on your video again by using the button in the left-hand corner. During the session, we will be doing some group work in breakout rooms. When it is time, you will automatically be moved into a breakout group by one of the MYT team, so no action is required from yourself. Once you're in your breakout room, please turn on your video using the button in the left-hand corner. You may also unmute yourself when you wish to speak and participate. Kindly mute yourself again after you have spoken to avoid any background noise. Once the group work is completed, you will return automatically to the main room after a 60-second warning. We ask you then switch your video and audio off upon returning to the main room. Please do take note of your facilitator's name when you move into your breakout room. Should you become disconnected at any point, we can use this information in order to add you back to the correct breakout room. If you wish to interact during the session, please use the chat facility on the virtual meeting platform. You will find this by going to the agenda tab in the virtual platform, clicking on your session, which you should have already accessed to reach this workshop. And hopefully, you will all have gotten an email on Monday detailing how to communicate during workshops with the chat facility if you're operating on one screen, so you can view both the chat and the presentation. Please email the MYT team, admin@nnnevents.com, if you're having difficulties with the chat facility, and they will be able to help you. The MYT team are here to help you with any technical difficulties, so please use the chat facility on the virtual meeting platform to ask any technical questions, or email them at admin@nnnevents.com, and they will reply to you immediately. So welcome to this workshop. Gender equality and inclusion are important for health and achieving the NTD roadmap and SDGs. And in this workshop, we will provide an overview of gender equality and inclusion concepts. This will be followed by short presentations on the Every Child Thrives project and how gender equality was integrated into the intervention. There will be one presentation delivered in French, but the slides will provide the information in English. Then the audience will have the opportunity to ask questions to the speakers before we break out into smaller groups for discussion. So my name is Sara Marshall. I work for Affect Hope in Canada as Programs Manager. And my co-lead for the workshop is Dr. Julien, a public health professional from Côte d'Ivoire involved in NTD control and elimination, and the Associate Director of Coptiment consultancy firm. We both managed the Every Child Thrives project over the past 4 years. We have 3 speakers joining us today. Karen Craggs-Milne is a leading global expert in gender equality, diversity, and inclusion, and the founder of Conscious Equality Incorporated. Dr. Oka Kwame is a public health specialist and director of the National Nutrition Program with the Ministry of Health in Côte d'Ivoire. Joseph Anyango has worked in the public health sector with MAP International and Helen Keller International, coordinating projects in Kenya. And now we'd like to get to know more about you and how familiar you are with gender equality and inclusion. So to participate in our interactive poll, please open a new tab in your internet browser. Use your mobile phone to visit slido.com and enter the code number 56933 to respond to the poll question. You can also take a photo of the QR code from your phone if that is helpful, and then you can just answer the question. So we have some results coming in. Good. So it looks like we have quite a few people who have done some work in gender inequality inclusion. Some others who have a lot more experience, or this is a new area to them. So this is quite exciting to have all of you together. So we'll keep the poll going, but we're going to also continue. And allow Karen Craigs-Milne to come in. So Karen has worked with us as the gender advisor for the Every Child Thrives project, and will provide us with an overview of equality and inclusion so we can learn more about these topics. Welcome, Karen. I invite you to take us through these key concepts.
Thank you, everyone. It's really great to be here with you today, and I am looking forward to your participation and interaction in the chat. Sarah, please let me know if, as I present, there's anything in the chat that we should talk to or speak to. So with the 20 minutes that I have, I'm just going to run through a few key concepts that have really informed the work that we were doing through the project, Every Child Thrives. Next slide, please. We'll start with the notion of sex and gender. And as you can see in this image, there's so much that goes into understanding the distinction between sex and gender, and then its implications for health-related programming. And so as you look at this image, I'd like you to just think in your mind, you know, what would you consider sex and what would you consider gender? Keeping in mind that sex is physical biology, and gender is about social roles and expectations. So I'll just give you a minute to look at the image. And as we're looking at the image, I just want to point out that gender equality programming starts by recognizing that women and men do not have the same starting point. Socially, we are in different starting points because of the different roles that we play, the different barriers that we experience, the different needs that we have. And those at the most fundamental level show up in terms of women versus men when you're looking at a biological perspective. But we recognize that, you know, we don't want to be fully binary in our conversation. There is the entire range with the LGBTQI2S community that includes transgender folk, gender diverse folk, people with gender fluidity, who also are impacted in different ways by health. And so, you know, at the minimum, we want to make sure that when we're treating communities or supporting communities, we do not go in with the built-in assumption that women and men are the same, they have the same needs, they're affected in the same way by the same barriers, because the truth is they are not. And so a very basic example around health programming would be that women would need support around maternal child health, which men don't need, but men should also be involved in supporting women through that process, their roles as partners and parents. And so how does health programming take into account both the biological needs, but also the socially related roles and needs and expectations that we have to ensure successful outcomes? That's the question that we try to answer with this lens when we're doing health programming. Can we move to the next slide, please? Another key distinction, so in the last slide, we talked about how sex and gender are not the same thing. Here, we're looking at the distinction between equality and equity. Now, I need to put this slide into context because for anyone who has done any work around this image, you know that there's actually multiple images. There's about 5 different images that is part of a much larger conversation on unpacking equality. But the key thing here for this image is, you know, distinguishing between treating everybody the same, which is what we talked about in the last slide. Everybody has the same needs, everybody has the same issues, everybody faces the same barriers, versus understanding that people have different starting points because of their gender and because of their sex identities. And as a result of that, to create really effective programming, we need to take that into account. So when we take differences into account to determine how we're going to go about rolling out a health strategy, that is called equity. And a quick example of this would be you create a health center and you tell everybody in the community, we've opened this health center for you, it's available to everybody. That would be, you know, equality in action. but we may not recognize that women in a, let's say in a community where women are not allowed to walk by themselves, they need to have a male guardian with them, or women don't have access to money, or they can't make decisions around leaving the house to go to the health center. They don't have the same freedom to show up at that center as others would, let's say men, for example. And so what else can we do to make sure that those factors are taken into account so that they can access that health clinic? For example, can we get the health clinic to actually have a mobile service that goes to people who are not able to get to the clinic by themselves? Can we offer transportation options? Can we have a male in the community who's designated to help those women get to the clinic if their husbands or their sons are not around? So that's what equity is about. Equity is really understanding what do we need to do, what are the different strategies we need to implement for different groups of people so that they end up with the same outcome. And equal outcomes is very different from equal treatment. You can see on the image under the word equality that everybody is receiving the same amount of resources, and that's called equal treatment. And often when we treat people in the same way, we inequalities or we reinforce existing inequalities. So very important that when we're doing this work, we use an equity-based approach. Next slide, please. We then apply, another level of understanding to ensure that our programming really reaches the needs and the barriers affecting people. It's to understand these 4 elements. So one is issues. When we're looking at health-related issues, we need to understand that from a gender perspective, there's 4 different levels that we need to consider. So access, like we just talked about the health clinic, women and men have differential access. They have differential control and decision-making. So in some cases, women have more control. In other cases, men have more control. Rights, the realization of rights. There's differential barriers affecting realization of rights for women versus men in that setting. And then gender-based violence. Gender-based violence is something that, mostly women experience, but young men and boys also experience it, and even elder men in certain circumstances. So when you're looking at a community and saying from a gender perspective, what are the issues that I need to be aware of? This is a framework that you can use: access, control, rights, and gender-based violence. On the other side, we want to make sure that we're asking those questions at multiple levels and that our intervention is also addressing those multiple levels. So individual, household and community, institutional, such as a health center, and systemic, so policies related to health. These 4 levels are very important when we're trying to create sustainable solutions that address issues that may affect users, but those issues that affect the users happen at multiple levels. So the combination of the 2, understanding the issues and understanding the levels at which we need to create impact and we need to work, are very important. We need both to do programming that's really effective. Next slide, please. Now here I want to talk about the distinction between gender integration, gender mainstreaming, and transformation. This is very important because not all types of gender programming are as effective. And so one way that people do gender programming is they say, okay, well, we're doing a health program. Let's just make sure that we include women. But there's different degrees to which we can include women and women's perspectives and needs. So one is gender integration, and gender integration would be to say, let's just add on to the way we normally do our programming. So it's adding on to business as usual. And the problem with adding on to business as usual is you don't have a transformative, sustainable impact in your programming. You have some change, but not the best situation. And so an example of that would be if you're opening, let's go to the health clinic again. If you're opening a health clinic and then you realize that adolescent girls need access to maternal child health services, you may just say the clinic hours are 9 to 5. We're just going to make sure that adolescent girls know that we're here to treat them as well. So you're doing business as usual, you're keeping the same hours, and you're expecting the girls to do what they need to do to access your services. But what we know from programming that I've done in Tanzania, for example, is that young women will not stand in line with their mothers and their grandmothers to seek maternal child health care because they don't want their parents to know that they're pregnant. They don't want to be judged by a highly judgmental community. And so they're not going to come to the clinic if you don't do things differently. So, one thing that we can do is say we have different hours of work for adolescent girls. Maybe they can come before the clinic starts or after the clinic starts. They can come in the evenings. They can come to a different location to receive services where other clients are not. Those are all examples of gender integration. And gender mainstreaming would be to say, okay, so we want to provide health services for this whole community. We recognize that adolescent girls are part of that community and that they have specific needs and sensitivities. Now, how do we design our health clinic and our health programming to actually ensure that the girls have been considered in how we develop and design the programming? So it's another level of planning for that group of people who have specific needs upfront as you're designing your project or your service. And transformation is a completely different way of doing programming, which is not often reached by most programming. But transformation would be to not only provide the services for the adolescent girls, but then to also say, how do we ensure that this doesn't happen in the first place, that we don't end up having such high rates of adolescent girls getting pregnant all the time? And so transformative health programming would go to the root causes and would say, okay, so we need sexual health education. We need to partner with the Ministry of Education. We need to partner with all these other partners to get to the root causes so that we're not constantly treating the problem, we're actually addressing it at the root cause. And so a transformation approach is really about ensuring that we're moving away from just the problem in terms of, how do we solve what shows up at our clinic, but also how do we look at this from a systems perspective? How do we look at this from a societal change perspective? And what does that mean for our programming? Next slide, please. So a key piece to the Every Child Thrives program and what made it so successful was understanding all of the elements that I've just presented and then creating what we call a gender-based analysis plus, which led to a very intentional, targeted programmatic strategy on gender mainstreaming and that really addressed the needs. And so I wanted to take a few minutes to talk about gender-based analysis and what it is. Gender-based analysis is a very intentional and thorough methodology that is used to understand the communities that you're working with, to differentiate who are the different groups, what are their different needs, and we're asking the questions, what are the roles that different groups play in this society? What are the different needs that they have? What are the specific barriers that they face? What opportunities do we have to consider here? And what are the risks that we need to take into account if we introduce any new intervention? And I'll give you a quick example. When we're looking at this program in particular, we were looking at disability inclusion as well. And one of the opportunities that emerged from the community gender-based analysis was that people who have disabilities, they don't congregate in the same place as everybody else, which is the market day where everybody gets together at the market, because they don't have the same mobility, but they do get together at places of faith. And so we knew that our strategy, if we wanted to reach people with disabilities, would have to include the element of organizing and reaching spaces of faith to ensure that we were also getting the message through to people with disabilities. So that's an example of the kinds of findings and insights you get from doing a gender-based analysis. And then you take all that information and you create a strategy. And the strategy has a number of elements to it. So what are your results? What activities are you going to roll out to achieve those results? And what are the allocated resources that you're going to use to make that happen? One example of a result would be that we want to reduce the number of adolescent girls that show up pregnant, or we want to increase the number of young mothers that go for ANC visits. These are all examples, and I'm not speaking specifically to the project because our speakers will do that. But just to say that in every kind of health programming that you do, there are specific gender equality results that you can achieve that will really impact the health outcomes of the communities that you're trying to help. And so how does the gender strategy fit within the programmatic cycle? Well, it fits on multiple levels. So right from understanding how we design the program, to doing the gender-based analysis, to creating a strategy that's implemented within the program, to achieving the results and monitoring those results and then reporting back on them, to learning lessons and adjusting your strategy. So gender-based analysis is not something you do only at the beginning or only in the middle of the program. It's something that has to be done beside and hand in hand with all the other programmatic work. And it needs to, as you'll see in the program example today, it needs to inform how you do everything else. So I hope this was helpful. If you have any questions, please put them in the chat and we can get to them during the discussion time.
Great. Thank you very much, Karen, for that it's brief but very comprehensive overview and explanations of these concepts, and especially this last slide around the gender-based analysis strategy and then how that works within our programs. So I want to thank you for that. And I will now provide a brief overview of the Every Child Thrives project, which provided combined deworming and vitamin A supplementation to children under 5 years old. The ECT project integrated deworming and vitamin A programs to address soil-transmitted helminth infections, or STH infections, and vitamin A deficiency that affect young children. So multiple strategies were used to reach all girls and boys during the distribution campaigns that took place twice per year. And it also addressed gender equality barriers related to child health and nutrition. Deworming kills the intestinal worms that absorb vitamin A and other micronutrients, taking these away from the child. But providing the combined treatment of deworming and vitamin A together is more effective in ensuring children absorb the vitamin A they need for proper growth and development. It also benefits the health system in providing multiple essential services together and reducing the financial and human resource burden for both the NTD and nutrition programs. So Every Child Thrives, or ECT, was implemented in Côte d'Ivoire and Kenya by the Ministries of Health and the county governments, and our partners MAP International and Helen Keller International, with financial support from the Government of Canada and Affect Hope, and drug donations from Vitamin Angels. A community-based gender analysis was conducted at the start of the project, as Karen has mentioned, and it was done in all project areas to better understand the local context and situation. The findings from the analysis informed the gender equality strategy for the project, which was used to address issues identified within the scope of the project. So the strategy focused on promoting equal provision of services to girls and boys, including children with disability, promoting women's decision-making and men's involvement in their children's health, and improving sex-disaggregated data collection throughout the project activities. So this strategy was adapted for each country and used to develop implementation plans for the gender equality and inclusion activities related to deworming and vitamin A programming. Including gender and inclusion into the programming helped the Ministries of Health to apply a gender lens to their programs and to consider gender differences. So our next two speakers will provide more information about how gender was integrated into the regular programming activities in each country, demonstrating how the gender analysis and strategy can be implemented in NTD programs to improve the equitable access to health services for all girls, boys, women, and men affected by NTDs. So Dr. Oka Kwame is the director of the National Nutrition Program in Côte d'Ivoire and responsible for implementing deworming and vitamin A supplementation for children under 5. And he was involved with the ECT project throughout. He will be speaking in French, but you can follow the slides in English. Hello, bienvenue, Dr. Oka. Je vais passer la parole à vous.
D'accord. Merci, Sarah. Tu vas couper. Donc, bonjour à tous. Donc, à la suite de Sarah, je vais présenter l'approche de l'intégration de la notion du genre dans notre programme de santé en Côte d'Ivoire. Je vais aborder 4 points. D'abord, l'approche, comment ça a été conduit. Après, je montrerai les performances du projet. On va parler brièvement des leçons apprises et puis on terminera par les défis. Diapo. Alors, le projet a eu lieu dans 8 régions sanitaires de la Côte d'Ivoire sur 33 que compte le pays. On est allé dans 32 districts, les 32 districts sur 113 districts que compte le pays. Pour une population cible totale répartie selon donc, les sexes, on avait 52% de femmes et environ 48% d'hommes. Et sur la cible des enfants de moins de 5 ans, on avait donc 52% de garçons et environ 48% de femmes. Diapo. Donc, comment est-ce qu'on a mené toutes ces stratégies d'intégration de la notion du genre dans la supplémentation en vitamine A et le déparasitage donc des enfants de moins de 5 ans? Diapo. On va rapidement rappeler la situation de la Côte d'Ivoire. Il faut savoir que on rencontre la carence en vitamine A. On a à peu près 60% des enfants qui sont à risque. Il faut savoir qu'on a connu quand même une baisse depuis 2004 d'environ 30%. Sur les géomentias, la Côte d'Ivoire est un pays endémique sur l'ensemble de ses districts. Donc, on retient que la carence en vitamine A et les géomentias constituent pour nous, pour la Côte d'Ivoire, un problème de santé publique de par leur prévalence, avec les conséquences que nous savons sur la population, avec la cécité, la dégradation donc, de la vue, une forte malnutrition de la population selon donc, les régions. Nous avons également 75% des enfants qui sont anémiés. Et puis, nous avons également un déficit, une baisse du rendement scolaire et l'absentéisme due à ces pathologies. Diapo. Également, nous avons procédé à une analyse de la notion du genre au niveau communautaire et nous avons ressorti des inégalités qui se présentent comme le pouvoir de décision et qui est réservé exclusivement à l'homme. On a noté également la non-implication et le faible engagement des hommes sur la santé de la mère et de l'enfant. Cela se voit lorsque vous vous rendez dans les centres de santé, qu'il n'y a que des femmes. Et puis également, nous avons la pratique discriminatoire dans le partage des repas, surtout sur les protéines. Les protéines sont réservées aux personnes adultes au détriment des enfants. Mais cette analyse du genre a révélé également des points positifs qui sont l'absence de croyance qui sera attachée à la vitamine A ou des parasitants. Donc, il faut noter qu'il n'y a pas une mauvaise perception sur le déparasitage des enfants. Au contraire, la population adhère fortement à la distribution de ces deux intrants-là et ils connaissent également les bienfaits. Aussi, ces intrants, le déparasitant et la vitamine A sont donnés aussi bien aux femmes qu'aux garçons et cela, la population nous l'a révélé. Diapo. Au vu de ce contexte et de cet environnement-là, nous avons donc procédé à la mise en œuvre de notre projet en tenant compte de la gouvernance et puis également au niveau de la mise en œuvre de terrain. Sur la gouvernance, il faut noter que nous avons pris en compte donc, la révision des outils de gestion sur la vitamine et le déparasitage en incluant la notion du genre et les handicaps. Cela a été un élément important. Également, nous avons développé des stratégies du genre. Donc, sur le projet Every Child, donc chaque enfant compte que nous avons conduit. Il faut noter également que nous avons mis en place sur la gouvernance un groupe de travail. Et ce groupe de travail a eu la particularité d'intégrer plusieurs ministères. Hein, parce que pour nous, il était important de prendre encore la notion de multisectorialité. Nous avons intégré donc, le ministère de la Femme, le ministère des Personnes, des Affaires sociales, de l'Éducation, qui, avec nous, donc, nous avons conduit tout le processus du projet aux différentes étapes de validation et de prise de décision. Diapo. Et cette image la montre un peu les acteurs qui ont contribué à la mise en œuvre du projet depuis donc, les décisions qu'on prend de façon consensuelle jusqu'à la mise en œuvre. Donc, vous retrouvez Dr. Ake, moi-même, les ministères de l'Éducation, le ministère de la Femme, vous avez les représentants des régions, vous avez également le corps préfectoral, l'administration. Donc, cela pour montrer un peu la multisectorialité avec laquelle nous avons abordé le sujet sur le projet. Diapo. Quelques résultats que nous voulons partager avec vous, c'est que nous avons procédé à la formation d'un certain nombre de personnels depuis le niveau central sur la supervision, la sensibilisation. Au niveau district, c'est environ 2441 personnes qui ont été formées sur la formation, la supervision et l'évaluation. Nous avons également intégré les ministères comme l'éducation. Nous avons également le ministère de la Communication à travers les radios de proximité. Nous avons également formé environ 17 000 volontaires, ceux qui donc vont distribuer les dépresseurs et la vitamine A dans les ménages. Diapo. Alors, il faut noter que nous avons bâti donc, notre stratégie sur les soins de santé primaires. Il fallait pour nous mettre en place toute la coordination, toute la gouvernance, mais nous avons développé notre approche en tenant compte des districts sanitaires qui sont organisés autour des centres de santé et autour, donc, qui délivrent les services dans la communauté. Donc, à cet effet, nous avons développé des outils de formation et de promotion. C'est les manuels de formation, des guides, des directives. Nous avons également produit des spots pour les radios à destination des radios de proximité. Nous avons produit également des dépliants. Et il faut noter que les messages à l'endroit des communautés étaient élaborés en langue locale pour s'assurer de l'accessibilité dans les ménages. Nous avons également assuré de façon annuelle 2 fois dans l'année, depuis 2016, donc début du projet, jusqu'en 2019. Donc, chaque année, donc, on avait 2 passages de supplémentation en vitamine A. Et vers la fin du projet, nous avons intégré des districts dans la routine. Et cette distribution communautaire est à l'endroit aussi bien des filles que des garçons. Et tous nos supports de communication avaient également montré cela. Un élément important que nous voulons relever, c'est aussi les lancements au cours de ces campagnes qui étaient assurées par les hautes autorités du ministère de la Santé. Et au cours de ces lancements, des messages forts à l'endroit des pairs qui, comme l'a révélé l'analyse situationnelle, s'impliquaient moins dans les questions de santé. Et c'était l'occasion, au cours de ces lancements-là, que soit le ministre ou ce représentant, donc, porter un message fort à l'endroit des populations, des parents, des garçons surtout, des chefs de ménage, pour qu'ils s'impliquent de plus en plus donc, dans la santé des ménages. Diapo. Alors, ici, nous vous montrons un peu quelques outils que nous avons, documents de référence que nous avons élaborés. Aujourd'hui, nous avons un guide de formation, donc à l'endroit des facilitateurs pour la supplémentation en vitamine A. Et ce document, c'est le document d'orientation qui nous sert aujourd'hui quant à la diffusion de l'information sur la notion du genre. Et aussi, nous avons des affiches que nous avons élaborées au cours des différentes campagnes de supplémentation qui montrent qu'il faut aussi adresser la supplémentation aussi bien pour les filles que les garçons. Diapo. Alors, toute cette mise en œuvre s'est appuyée sur un élément important, à savoir la gestion de l'information sanitaire. Donc, fait majeur pour nous, c'est que nous avons développé et utilisé des outils qui intègrent la notion du genre. Et c'était, je crois que c'est un des points importants pour nous que nous voulons partager, c'est que dans la présentation des outils de collecte, initialement, on s'en tenait aux normes, aux cibles. Nous avons intégré la notion de la cible totale, mais également la cible de la fille-garçon dans les outils de collecte. Et à la fin de chaque campagne, on collectait, on faisait l'évaluation qui nous permettait donc de savoir quel était le niveau d'atteinte au niveau des filles, au niveau d'atteinte au niveau des garçons. Et également, nous sommes dans un processus d'intégration de ces notions-là du genre filles-garçons dans la désagrégation de la collecte de l'information dans le système d'information, donc le DH2, que nous utilisons pour les formations sanitaires en Côte d'Ivoire. Diapo. Ce projet nous a permis donc d'obtenir des résultats très significatifs dans le cadre de la lutte contre les carences en micronutriments. Sur les 32 districts que nous avons, qui menaient donc à nous le projet, tous les 32 districts ont conduit depuis 2016 donc la supplémentation annuelle, donc 2 fois dans l'année. Et on a utilisé, comme je l'ai noté tantôt, des volontaires qui étaient constitués d'hommes et de femmes. Dans nos statistiques, nous en avions 66% d'hommes contre 34% de femmes dans notre distribution communautaire. Et nous avons utilisé des outils de collecte, comme je l'ai dit tantôt, de nouveaux outils qui intégraient la notion de filles-garçons au niveau des districts. Nous nous réjouissons, Diapo. Nous nous réjouissons également de l'atteinte de la cible filles-garçons au cours de ces 4 années de projet. Comme vous voyez sur les diapos, sur la couverture en vitamine A, vous notez que les filles ont été aussi bien atteintes que les garçons sur l'ensemble de nos évaluations au début, à mi-parcours et à la fin du projet. C'est au moins 90%. Au moins 90% des filles, 80% des filles et garçons qui ont été donc touchés depuis le début du projet. Quand nous prenons les déparasitants également, c'est dans les mêmes proportions. C'est 95% d'enfants qui ont été atteints à mi-parcours du projet. Mais au total, nous notons que les filles et les garçons ont bénéficié du déparasitant et des garçons dans les mêmes proportions. Et ça, c'était important à relever. Diapo.
Vous avez 1 minute.
Quels sont les succès donc, de ce projet? Nous retenons que l'inclusion de la notion de filles et garçons dans la collecte de nos informations a été un élément important. Et nous sommes en train donc de l'inclure dans le système d'information générale. Également, l'implication des femmes dans la mobilisation a été un élément important et nous l'avons relevé. Les femmes ont bénéficié de la distribution communautaire aussi bien que les garçons. Également, nous notons qu'il est important aujourd'hui d'assurer la pérennité de ce projet-là au vu donc des résultats que nous avons. Sur je crois que les défis. Alors, les défis, c'est ce que je venais de noter comme l'intégration des données dans le DH2, l'implication des femmes, la pérennisation des acquis. C'est ce qui est, nous notons comme défi. Donc, le DH2, pour nous, il est important de pouvoir intégrer les données, mais continuer la mobilisation des femmes et puis également la pérennité. Mais je voudrais noter qu'un élément qui est important sur les leçons apprises, je voulais juste revenir dessus. Voilà. C'est la notion de multisectorialité avec nos partenaires. Pour nous, l'éducation était partenaire clé sur l'atteinte des cibles. Et nous avons avec eux pu atteindre cette cible-là. Les enfants du primaire sur la tranche d'âge de 0 à 5 ans, il nous fallait également associer le ministère de l'Éducation nationale, mais aussi le corps préfectoral qui mobilise dans les communautés. Également les programmes de vaccination sur la cible de 0-11 mois qu'on a associé également à la mise en œuvre du projet. Et puis le programme de lutte contre les maladies négligées avec qui était également membre du GTT et avec une partageant des expériences de lutte contre les maladies négligées. Et puis, je voudrais relever également le soutien du ministère de la Santé à un haut niveau. L'implication du ministre de la Santé, déjà depuis la signature de la Convention, et puis leur présence au cours des lancements biannuels marquait donc vraiment le leadership du ministère de la Santé dans le projet. Et puis également, on note que de plus en plus avec ce projet-là, nous avons noté la présence des hommes. Voilà, la présence des hommes, et les évaluations nous ont montré que les hommes aujourd'hui donc peuvent nous dire ce que c'est que la vitamine A, ce que c'est que le déparasitant, et y contribuer à la mobilisation. Donc voilà des succès clés que nous avons voulu partager avec vous, et nous pensons que sur les défis que j'ai tout à l'heure partagés, on peut se projeter sur les perspectives. Donc, diapo. Oui. Donc, sur les défis que j'ai partagés tout à l'heure, qui nous permettent aujourd'hui de nous engager sur trois éléments majeurs. Le premier, ça porte sur l'intégration des données. Mais avant ça, il y a les hommes. C'est comment travailler sur les hommes pour qu'effectivement, ils puissent continuer leur implication dans la question de la santé des enfants. Mais aussi, pour nous, il est important de poursuivre la mobilisation et la participation des femmes. Et après, c'est la formation des acteurs sur le genre. Nous pensons que nous avons pu bénéficier, grâce à ce projet-là, d'intégrer la notion du genre dans nos documents, dans notre approche. Mais aujourd'hui, il faut qu'on forme les différents acteurs, qu'on poursuive la formation. Et on voudrait terminer par dire merci vraiment à EFET-HOP pour l'occasion qu'on a eue pour ce projet sur 4 ans. Je crois que c'était une des opportunités que nous avons depuis quelques années de conduire un projet durant 4 ans et d'avoir ce résultat-là. Donc, on vous dit merci et on espère pouvoir continuer sur les défis que j'ai partagés. Je vous remercie.
Merci, Dr. Oka, pour votre présentation. Thank you very much, Dr. Oka. Our next presenter, Mr. Joseph Anyango, was the ECT project coordinator in Kenya. He worked closely with the National Ministry of Health and the county governments of Kilifi, Kwale, and Siaya to implement the project. So welcome, Joseph. I'll pass over to you for your presentation.
Thank you very much, Sarah, for the opportunity. I'm going to share the Kenyan journey of the ECT project from the NGO perspective. You can see from the photo, there are some men who are deep in thought. That was one of the participatory communication methodologies that we use to engage the communities. That was Ganze in Kilifi. Next. When we began the project, deworming and vitamin A was being given as 2 separate interventions. And basically, year 1 to 3 were being missed out. So we wanted to make sure we are including them. And as Sarah has shared in her presentation, when deworming and vitamin A is given together, there is more benefit. And we also conducted a study to understand gender in the communities that we were working in. And to our shock, there were no gender equality protocols that had been developed to help with the health services. We also found out that women would just take their kids to the health facilities, whereas the men would facilitate their travel. If a man was seen carrying a baby to the health facility, the other men would laugh at them. And the assumption within the society was that they are either overpowered by their women or their cabbages. So that was a very strange thing and a big deterrent to male involvement in maternal, neonatal, and child health. Next. As a result of the gender analysis, we came up with a roadmap to be able to help us to chart out our intervention. And one of the documents was the Gender Equality and Inclusion Strategy. This was a consultative process where we put together different stakeholders from the different counties to ensure that the activities were gender sensitive and also participatory. So the messages were passed through songs, edutainment, meeting with different and various groups like young mothers, people with living with disability, and so forth. Next. We also developed a document called Community Communication and Engagement Strategy to increase the demand. The different communities have different dynamics. So we also had a consultant get on board, and we went to the different counties to ensure that the activities that we are going to have are going to be addressing the gender barriers. So basically all the activities that we came up with, we put them in implementation matrix, and we were able to follow them up throughout the project. We also developed training and reporting tools. The interesting thing is that when you mention gender in the community, they would imagine that you have come to empower the women to overrule their husbands. So it was a very, very tricky part. When you talk to the health personnel, they would imagine gender is basically gender-based violence. But for us, we wanted to reach the unreached, girls and boys in different parts. Next. You may ask, how did we plan all this and implement? For sustainability, we were able to work with the technical working groups in the different departments in Ministry of Health. For example, we worked with child health, we worked with the Department of Nutrition, and even neglected tropical diseases. At the NGO, we worked with the coordination fora in different counties. We discussed the achievements, best practices, and also addressed some bottlenecks. Of key importance was the county teams, whereby all the gender analysis results, along with the project results, we made sure that these are actively infused and integrated into the programmatic activities. For instance, the in-laws, the mother-in-laws in the western part of Kenya were very influential in the health of the child. So basically, when they said the child should not be taken to the facility and given the herbal medicines, that was very, very critical. So during our meetings, we were able to identify that, and we engaged them in meetings using the gender dialogues to be able to address those problems. In coastal provinces, the Mwenye syndrome, there's something that they call the Mwenye syndrome. The owner of the home had to give permission for any activity to happen, including taking a child to the health facility. So the mothers really depended on these people. And if they were not available and they were not supportive, it would really give a big problem. Next. That is supportive supervision. That was an activity that takes place during the distributions. And you can see all the actors are there, the health facility, in charges. We have the Effect Hope. Dr. Ake is in the photo in a white shirt. I'm not there because I took the photo. This is a spot check during the interventions to ensure that gender is being mainstreamed, the facilities are taking the data correctly, and that everything is working out fine. And basically, when we get a problem during this time, we're able to discuss it at higher levels in order to bring in better results. Next. The results show for themselves. The number of health personnel trained, we had more ladies, 66%, and the males were 34%. Combined deworming and vitamin A coverage for the under 5s, you can see we had 78.6 girls percent, 79.8% of boys. I'm proud also to inform that in all the 3 counties, we have the new data collection tools in use, and they're using them right now, disaggregated in sex, age, and ability. Next. The outcomes, under the outcomes, the reporting tools I've just mentioned, they are in use and they are engendered to capture gender aspects of vitamin A and deworming. But then I want also to mention about community gender dialogue. For those who are not familiar with this concept, this is a participatory activity at the community level where the leaders come together and convene a meeting and all the stakeholders come together, and the main discussion is on the child health and gender. And we gear that towards men's participation and women decision-making for positive child health outcomes, because that was one of the problems or the barriers that we realized during our gender analysis that we conducted at the beginning of the project. And then we, through the focus group discussions, we monitor the progress and gender integration. So this is done quarterly and it's already happening. It is something that we left so that even as the project phases out, this is also happening in terms of making those and we were looking at evidence generation. How are we doing the advocacy and awareness? Is the capacity building happening and how is it happening? Service delivery. And then what are we learning through the process? So we would engage the community in focus group discussions, but we also engage the health workers at county level. Next. There are some successes that we can be able to share together. One is on data collection and reporting tools. This was a key weakness in the areas that we worked in. Of importance also was the training materials and job aids, and these have helped improve the gender programming. So we developed tools for the community health volunteers. That was one level, a lower level or a lower cadre. Then we also had one for the health workers. And then the documents that I alluded to earlier, gender equality strategy and community communication and engagement strategy, they're also in use in the counties to mainstream gender. Next, please. The challenges, even though the data is collected and disaggregated by sex in the counties, it has not been captured in the Kenya Health and Information Systems. Sorry. So what is happening is that is work in progress. So to be able to do that, the government is still working on the plans to ensure that that happens. Additionally, there was a high turnover of health staff and community health volunteers, and this affected the cascade of the gender activities to the front line health workers, because we wanted to reach every distribution point to ensure that this gender integration message has reached everyone. Next. As a way forward, we developed a toolkit for doing vitamin A and deworming with the gender lens. So the health workers are able to benefit and community health volunteers are able to benefit from it. So this is for scale up in the counties that we did not work in. We worked in 3 counties out of 47. So the other counties were really interested. So we developed that toolkit to ensure that the others are also benefiting. And finally, I want to say that there's need to advocate for the county health teams to allocate more resources to train and roll out gender programming, because this is something, a concept that is still new. And there's a lot of need to be able to roll out that. So the counties need to come up with ways of raising more resources to be able to achieve this. Thank you very much. I'm available for questions or any clarifications.
Thank you very much, Joseph, for sharing your presentation. As Dr. Oka and Joseph have mentioned, there are key lessons that we have learned from this project, especially that the gender analysis is critical for understanding context and gender-related barriers in society that affect health. We also observed different ratios of men and women in the health personnel trained in the 2 countries, with more men involved in Côte d'Ivoire and more women involved in Kenya. So this could be an interesting area to look into in future in terms of how does the gender of health workers influence service delivery and the ability to reach all girls and boys in MDA campaigns. The ECT gender activities were not given much budget in this project, and this limited the scope of the gender work that could be done, even when integrating gender into the main project activities. Recommendations from the project evaluation stated that multi-sectoral partnerships should be extended to social ministries and include women and people with disability. And this was emphasized by Dr. Oka. This would improve understanding of gender equality and disability across sectors and ensure that NTD programs are equitable and appropriate for everyone. So Dr. Julien Ake will now moderate a question and answer session with the speakers to give you an opportunity to ask them some questions. And during this, you may want to change your presentation view options in the top right corner to see the speakers more clearly. Julien, welcome,
Yes.
Julien, for the Q&A.
Thank you very much, Sarah, and I'm glad to take over from you. I want to say good morning or good afternoon or even good evening to the participants. And I would like to mention that for this session, we will use the chat box for questions. I will not give opportunity to people to open the microphone and speak, but rather we want them to send the question through the chat. So far, I have noted a question from a participant named Ebwa that I'm going to ask to Karen. And then I have some other question which has been prepared that I will ask to the other speaker like Joseph and also to Dr. Oka. So the first question, I think Karen has been already chatting with Ebwa, but I want to recall it because it is a very interesting question that could be interesting for the whole audience. The question is stated as like this. Can this gender equality and equity concept be applicable the same way both in open and closed communities? And the one who asked the question provided some explanation about what is defining as open and closed community. So closed community are highly conservative with respect to beliefs and cultures relating to gender, while open community are highly interactive group. I was wondering if the same impact can be attained in both cases. So, I mean, Karen, I know you have been chatting with the one who asked the question, but I would like you to speak louder for the whole audience for this very important question.
Thank you for the question, and thank you for bringing it back up, Julien. This is very important because, you know, I've worked all over the world, and sometimes the response I get when we're looking at integrating gender equality in programming is the culture is not open. It won't allow for us to talk about women's rights and empowerment, which is a key element of ensuring that we have, you know, healthy outcomes for women, for men, and for children. And so I just want to address that upfront by saying the key here, first of all, it applies to all societies and all contexts and all cultures, whether you're highly conservative or whether you're open Western culture. Equity, equality, social justice, these issues impact everybody because we all have different roles, we all have different needs, we all experience different barriers. And so this, you know, bringing that lens to how you design and deliver initiatives is just good practice. Without it, you're not going to meet people's needs. But the second thing I want to say around this is that it's really, really important that the success of the program is based on how we introduce these concepts and how we engage local communities in their understanding. Because as has been the case in Tanzania and Ivory Coast and Kenya and many other countries, people have their own understanding of what gender means. For a lot of people, gender work is a Western concept. For a lot of people, gender work is about making women men. You know, it's about taking power away from men. It's about breaking up families. So when we bring this work into communities, they already have a certain understanding or interpretation. And it's very important that we start by addressing those myths and those misunderstandings so that we can say that this work is really about creating partnerships and conditions that enable a mother to take a sick child and get to the health clinic in good time, or that enable a father to participate in their child's health and well-being. It's not about turning men into women. It's not about making men into, you know, women into men. It's about ensuring that we have good health outcomes and that everybody plays the right and the appropriate role in that process. And of course, a key element of that work is helping women have more decision-making, have more access to resources, changing gender roles around men and socialization So there are pieces of this work that can be uncomfortable in terms of the social transformation aspect, but definitely at minimum, what we're trying to do is make sure that we're meeting needs. And so education around this is very important.
Thank you very much, Karen, for this very well-developed answer. And I hope that Mr. or Mrs. Iboa is happy with the answer. Some more questions are coming, and one is related to data collection to inform gender equality in terms of service provision. So I had another question coming from Daniel. Daniel, question will be directed to both Joseph and Dr. Ruka. I will start with Joseph first. So the question is that one. Thank you for the presentation. Would it be possible, so Joseph and Dr. Ruka, would it be possible to explain which measures of abilities were captured via the data collection tools and how far up of the health system those data were subsequently captured? So Joseph, can you start with your answer, and Dr. Ruka will complement. Thanks.
Thank you very much, Julien. I want to share that our data collection tools had a section on disability. The data collectors would go around, and the disability that would take note of was a physical disability. So basically they would just check as they're doing the service delivery, and they were able to chart and then take note that this child has a certain disability. So basically we based it on physical disability.
Okay, so thank you very much, Joseph. I will turn now to Dr. Ruka. I was translating the question in French for him, so now he got it. So Dr. Ruka, can you give us some response about how data has been captured within the system to inform gender equality?
D'accord. Sur cette question, l'indicateur que nous avons collecté sur le genre, porté sur le sexe, mais aussi il faut noter que les ménages, au-delà du sexe, filles et garçons, les lieux de provenance des enfants également étaient collectés. Et également, il faut intégrer la notion d'handicap, qui n'est pas directement concernée ici, était collectée sur les fiches donc, des agents volontaires.
So Dr. Ruka is saying that during the implementation of the, So Dr. Ruka is saying that during the implementation of the project, information which has been captured were related to the sex of the target children of the project. Those are children under 5, age 6 to 59 months. So it is the data collection system is capturing those information from the community level through the health facility level, and finally, those data goes to the health district level where they are aggregated to be used in the national statistic. So beside the sex, which are information on the sex which has been collected, some other information has been collected about disabilities, children with disabilities, simply because this is another notion we took into account in the project, because children with disability in the places where those activities has been run were kept in the house and not presented to the people making the distribution of commodities once they are visiting the household. So this is another data which has been collected to ensure that all boys and girls, regardless to the status, disabled or not, are benefiting the intervention. So to summarize, data related to children with disabilities has been collected. Second, data related to the sex boys and girls has been collected. And this has been done through the whole system, from the community level to the top level of the health system in Côte d'Ivoire. So with those answers.
Yeah. Thank you, Dr. Ake.
Yeah.
I think there is one question left, but we will try to get to it in the chat box, I think, because we do want to move into the breakout rooms and make sure that we can have some small group discussion. So thank you for sending those questions in. So we're going to move into breakout groups in 4 groups to answer and discuss the questions that are shown on the slide. Each breakout room will have a facilitator. So it's either Julien, Karen, Joseph, or myself to facilitate the discussion for about 15 minutes. And then we will return to the large group to share some of the main points that emerged from the discussions. The questions, they will also be written in the chat box in a minute, so you can refer to them. And we will be moved automatically into a breakout room, so you don't need to do anything. So Debbie, if you could move us into the breakout room now.
Thank you, Sarah. Yes, I'm just going to open the rooms. It will just take a couple of seconds.
So welcome back to the main session. We hope everyone had a fruitful discussion in their small groups. I'm going to ask the facilitator from each group just to share some of the main points that came out from your discussion. So if you can take just a very brief minute each. Julien, can we start with your group, please? Julien, you're on mute.
Yes, thank you very much, Sarah. We had a very fruitful discussion, even if the time was very limited, but I will provide 2 things. One regarding the question 1, and the second would be about the question number 2. So question number 1, what are the key points you have taken from the workshop on integrating gender equality on NTD intervention? What we have mentioned is that integrating gender equality and equity in a program requires a strong component of community engagement and communication strategy. Did you get it? Yeah, that is what we said regarding the question 1. Because time is limited, I'm going to give another answer regarding the question number 2, which is really interesting. Question number 2, what we said is that there is a need, once you want to integrate gender equality in an intervention, to get some, to build your intervention based on existing evidence of gender equality consideration within the community you want to work, or even within a broader spectrum of researches which has been done about that. And for me, starting this intervention with this community-based analysis has been a key point to develop a good strategy to answer those questions. So These are the 2 things that we can communicate for now. Thank you.
Thank you very much. Karen, did you have anything you wanted to add from your group?
Yeah, a number of really great points. So one was the importance of data collection, not only on male, female, but also disability inclusion. So, really unpacking what kind of data we're collecting so that we can tell a better story. And one of the challenges there is data synchronization. So you could have a project that's doing amazing work, but is that data synchronizing up to national level data systems? And what can we do to kind of build that into programmatic interventions? A key takeaway was, really thinking about the role of men in health outcomes and how we can engage them more strategically in other initiatives, as well as looking at, how do we roll out the education and training? One lesson learned was that it's really helpful to have gender equality as modules within all the training that's cascaded out to community health workers and others at all levels. So ensuring that it's not a one-off thing over here, but it's brought up consistently in all the different trainings and discussions. We also talked about, you know, what does it look like to assess the impact? So you're doing all these trainings, you're having all these education sessions. How can we make sure that we're having an impact in terms of what people are internalizing and learning, and then how they change their practice in their service delivery? So there we talked about the importance of setting up the pre and post assessments before training and after training right away for immediate understanding of have people understood, but also assessing the downstream impacts of that conversation or that perspective. One of the things that we mentioned was, you know, how when you're training healthcare workers, there's a ripple effect in terms of how they then interact with other healthcare workers, but also how they bring this work back to their families and communities. And that led to the last point, which was around, you know, not only looking at, are we achieving the intended outcomes of the intervention? So the health outcomes, are they changing? Are they better or not? But also, what are some of the unintended outcomes as a result of bringing a gender lens to the work that you're doing? So for example, a lot of interventions achieve the health outcomes, but in the process, they also create new issues such as an increase in gender-based violence, etc. So are we looking at both planned outcomes and unplanned outcomes and how they're connected to the gender work we're doing?
Great. Thank you very much for sharing. Joseph, do you have any additional points quickly?
For our group, Anna was the one who took the points. So Anna, we can then was going to share.
Anna, please. Just a couple points.
I was nominated. So I think actually almost exactly what was outlined by Karen came up in our group. Also the importance of the situational analysis and, you know, being really struck by some of the examples that were given. And this idea of the difference between equity and equality was a really helpful difference to be aware of. And then also we discussed in terms of like next steps, finding ways to identify specific barriers for men and taking that kind of masculinities and male engagement lens to the programs. And then we did also talk about this data and data capture and how you can capture data when you're looking at multiple variants in a really sustainable way. And then the final kind of main point was about sensitization in NTD or mass drug administration and whether or not it's too standardized and whether or not the standardized way of doing it could be adapted to be more contextualized and make sure it's actually reaching everyone it needs to reach.
Great. Thanks, Anna. From our group, we also had questions around sustainability. So how do we really pursue transformation in our programs? Because they're not gender programs, they're health programs. So that was a big question too, looking at roles and responsibilities. And realizing that there are people in certain cultures who are not able to speak out. And so, you know, what impacts can both men and women make in this area? Then we also were speaking more around we might have equal numbers of men and women, but, you know, we need to go beyond that. And we need to try and also have more equality at different levels within the health system, not just at the volunteer level. And again, looking at both gender and disability and intersections of gender with other aspects of demographics and gender roles. So getting a little bit more deeper into maybe what we're doing already, but we're still in the integration mainstreaming phase, and we need to see how we can do a little bit more. So that was some of our discussion. So I want to thank everybody for those group discussions. It was wonderful to hear the lessons that we were sharing just now, how these can be applied to your NTD programs and interventions. And we look forward to seeing these improvements across our NTD community so that we can achieve the NTD roadmap goals and leave no one behind. NTDs can impact men and women differently, and people of different genders can experience NTDs in different ways. And so it is important for us to remember this and to be more proactive in looking at our programs and interventions through a gender lens, to see and understand how different people are affected by NTDs, but also to find ways that our NTD programs can address inequalities to reach all women, men, girls, and boys. So I want to thank you all for participating today. I want to also thank our speakers for joining us today, the NNN and the MYT team as well. And we would like to acknowledge and thank all the sponsors for the workshop today, and we hope you have an enjoyable evening or afternoon or rest of your morning.
Thank you.
Thank you very much, Sarah.
Thank you.